Good afternoon. Thank you, Ben, for that generous introduction. I'm really honored to be here to share my work and how Dana-Farber supports my patient-centered approach to research and how I try to translate discoveries to bring them to patients as soon as we can. So I'm an oncologist and a clinical investigator. As Ben mentioned, I have the extreme pleasure of taking care of adult patients with blood and bone marrow aggressive cancers. And when I'm not taking care of patients, I think about the questions that come up in clinic, and we come up with ideas, and we start to design clinical studies. One of the great privileges I also have, in addition to take care of patients, is I'm surrounded by phenomenal scientists. And so I've been able to have the opportunity of bringing this science directly to patients by translating their findings into good clinical questions, and then figuring out in the context of trials, has this made a difference or not? So one of the diseases I really take care of and spend a lot of time on is acute myeloid leukemia, or AML. And in the last 5 years, we've had tremendous success, and our therapeutic arsenal has really expanded. And it's really been fantastic because some of the patients we wanted to take care of before with better therapies, we just didn't have the drugs available. And as an example, the majority of the patients with acute leukemia are actually an older patient population. And nearly 5 to 10 years ago, the treatment options we had were primarily palliative. And now with treatments available today, we can actually induce things called remission, and that means getting a response, getting count recovery. We could actually extend life outside of the hospital, and it's been extremely meaningful for us to see this happen to patients. I want to spend a second discussing that, primarily because a lot of the early work that came to us being able to change the treatment arsenal came from our own very backyard, along with others around the world. We helped to move forward a 2-drug regimen with an IV drug called azacitidine and a pill called venetoclax that targets the anti-apoptotic protein BCL2. And together, this treatment has really changed how we manage and take care of patients. And it's part of the backbone of some of the novel regimens I give to keep chipping away at this problem at how do we keep disease from coming back. So I want to take a second to tell you a little bit about the story of venetoclax because it comes from our own backyard here. So data from the Dana-Farber labs of the late Dr. Stanley Korsmeyer, and then later on with physician scientist Dr. Tony Latai, who was a long-term collaborator of mine, they helped to discover that targeting the apoptotic machinery was really, really critical for treating cancer and preventing it. Apoptosis is a form of programmed cell death, or in other words, it's how we get cancer cells to die. And they were able to identify that there are different levers that can push cancer cells to the brink of cell death, to the point of no return. And in fact, there were drugs that were available that could target these levers, and it could help us to get better responses in patients. So this then led to clinical trials in humans with AML after these discoveries were made in the lab. And when they started giving drugs like venetoclax, which target BCL2, they were able to see some responses, but when they started combining it with other drugs, the responses were very robust. And so together with colleagues all over the world, through a series of clinical trials, we confirmed that responses were good, and we confirmed that this improved survival, and this then led to an FDA approval. So this combination of azacitidine and venetoclax has really revolutionized how we think about AML and what we can do for our patients. So despite this monumental advance, which was really important for all of us because it gave patients more options, there's still quite a lot of work to do. We know that in many cases of AML, there is sometimes stubborn disease. Stubborn meaning it doesn't like to get into remission, doesn't like to go away. And we know that sometimes these responses, as Ben mentioned, they're not deep enough. And that means that it could represent a harbinger for a problem down the road. So how do we take this recent development and build on it? And how do we keep moving the field forward so more patients can benefit today? So to best illustrate some of my work at Dana-Farber, I thought it'd be great to share a patient. I got her permission. She's recommended to come to Dana-Farber through her family after she was unfortunately diagnosed with acute myeloid leukemia. And she's agreed to let me tell her story because it's a great example of Dana-Farber at its best. So while this does not completely capture the essence of Joan, she's an incredible woman, extremely bright and lovely and super friendly, but 3 words that I think that she wouldn't argue with that really capture her essence. She's fit, she's older, and she's motivated. And she has really fantastic support from her family. So why did I elect Joan as an example for our discussion today? Well, one, Joan represents many of the patients Patients with AML tend to be older in age, and so the treatment options have to be really thoughtful so we don't make patients sick in the process while we take into consideration other medical issues that patients could be living with. So her story is really one of many and not an exception. And two, Joan is really motivated. She wants to know, are there clinical trials? Is there something beyond usual care? She was aware of the fact that her leukemia was stubborn, and she wanted to know, is there anything else that we could do? And three, her story illustrates really what we can do today at Dana-Farber. So in summary for her, she actually went on to 2 clinical trials, one to treat her cancer and then one to try to prevent the disease from coming back. And spoiler, we got her to transplant just a month ago, which is really fantastic. So how did we do this? And I think we should take a step back and go back to when I first met her. When we reviewed her case, we had reviewed that unfortunately it looks like her type of leukemia was a stubborn subtype. And so our expectations, based on the available data and clinical experience, was that with the current standard of care, which is the 2-drug regimen I just mentioned, or the usual care, it might not have been enough to get her into remission. So what do? When we have knowledge that standard of care is not going to be sufficient, this is exactly where clinical trials need to be. It's exactly the space that we need to expand, and this is where we have the responsibility to make sure we have options for our patients. So what can we do at Dana-Farber? So while I've been taking care of patients, I've had the phenomenal opportunity to work with my laboratory colleagues to try to think about how we could design other studies and how to ask questions in the lab and bring them into the clinic. And so one of the questions I had been thinking about is, especially given how active targeted apoptotic pathway had been, are there other anti-apoptotic proteins that are vulnerable and could be leveraged in leukemia and even in resistant subtypes that maybe were overlooked because we had focused on venetoclax this entire time? And we did, in fact, find in the lab there's another target called BCL-XL. It's a cousin protein. And what we found is that this looked like a good vulnerability for resistant types of leukemia. So with a lot of convincing with the drug companies, we then designed a novel trial. So we call this translation, where we find something in the lab, get some good, solid scientific evidence, build a story, and we translate it into a clinical study. So we went from this 2-drug regimen to now a triplet study, where we added a 3rd drug, which was a pill that targeted that BCL-XL that we had identified in the lab to be a potential vulnerability for her cancer. And so Joan consented to this trial, and after a few months of being on the treatment, she had only needed to spend a couple of days in the hospital, which is fantastic. The rest was outpatient. She very fortunately got into a remission. What is a remission? A remission is when we don't see cancer cells by eye, counts come back up, and that's just the start of getting good disease control. Now that we had reached this really great point, a question became, what do we do next? How do we keep this stubborn disease from coming back? And this, unfortunately, this issue of stubborn disease recurrence, this is an issue that is common to many types of cancers. And so new strategies are needed across the board. So to best illustrate why leukemia might come back, I have this visual here I think that is helpful, and it's an iceberg. And while it's not a perfect analogy, it kind of gives you an idea of what we're dealing with here. It's a good representation of our problem. One of it mainly being is disease burden. And so how does this really relate to leukemia? Well, when patients are diagnosed with leukemia, disease is really relatively easy to pick up by eye. We can see what's on the surface. But when patients get into remission, that's where things go under the surface of the water. We have no idea what's left over. And so why does that matter? We have liters of blood and bone marrow in our body, so we really need good detection and we need good treatment available in order to keep eliminating what's left over. We call this disease beneath the surface of the water, measurable residual disease, or MRD. And that's really something that's common to many types of cancers. How do we get rid of leftover disease? How do we avoid overtreating? How do we avoid undertreating our patients? And can we improve the sensitivity and specificity of our detection tools? So one way to take a look at that is to ask the question, does MRD even matter? Yes, in most, but not all, when there's presence and persistence of MRD, it negatively impacts survival, and that's because it leads to a disease coming back or recurring. So what do we know about icebergs? The largest portion of the iceberg is beneath the surface. So there's a lot of responsibility on us to make sure we have good detection tools available and to make sure we offer treatments that don't make patients sick in the process to keep chipping away at this leftover disease. So at Dana-Farber, as one way to try to answer this question of MRD, we're collaborative. And this is another aspect that makes our organization really phenomenal and unique against other institutions. And through a powerful collaboration and with the strong support of a forward-thinking organization called Breakthrough Cancer, we're collaborating with other institutions to try to improve our ability to detect this leftover disease and to come up with novel ways to try to treat it. So what are we doing in the meantime at Dana-Farber? I want to spend a moment telling you about a clinical trial that we developed to target MRD as it's relevant to our patient. So when we get a patient into remission, getting back to her story, we ask the question of, is there any role for something called a stem cell transplant? Is there any way we could leverage an immune system to try to keep getting rid of disease? And one of the burdens of transplant is the success of it is really going to rely on how much of that leftover disease is available in a patient, and when we send them to transplant, we got to make sure that burden is as low as possible. So one of the ideas that we've had is trying to continue therapy in patients at low doses to provide them with safe continued treatment to keep chipping away at the disease beneath the surface so we can offer them that curative next step. And this is really relevant to our patient, Joan, because she ended up going on to this clinical trial that we developed. And initially, this clinical trial relied on philanthropic support to get started. It included using a pill called venetoclax again, which we know can increase the potency of therapies. We added it to the transplant chemotherapy, and then we gave it at lower doses afterwards with the goal of trying to keep it for coming back. So what happened with our patient? She went on to this second clinical trial, this bold patient-centric study, where she underwent transplantation. And in this therapy, she was able to do the majority of it outpatient, which is really phenomenal. And she was able to get through this experience, and she's just 1 month out. I'm grateful for brave patients like Joan, who allow us to test new therapies so that we could try to improve the treatments that we have available today. And I'm grateful to Dana-Farber and generous donors like you, who allowed me to give more options to patients to move the field forward. Thank you very much for being a part of this remarkable community.